So let's go ahead and finish a few loose ends here on the shoulder. Some things that I was a little bit confusing about a few days ago. But so let's start here. Jeff, why don't you take this case?
Okay. 2-year-old female? Okay. Right chest wall swelling for 3 days, uncertain trauma history, and we have ultrasound images of presumably the right chest wall. I saw something echogenic on that ultrasound, and 6 days later.
So this is the area we're interested in over here.
Okay. It looks like we're on a sagittal view and an axial view, and there's definitely this heterogeneous echogenic. It looks like some kind of heterogeneous echogenic material, maybe calcification of some sort within the musculature.
So there we go. Here's the MR. So
okay.
There's a little fluid collection on that.
Right. All right. So in these MR images, looks like we have a T1, T2, and maybe a post-contrast image, or let's see here. But essentially,
T1 and a PD fat set, or a T. This looks like one fat set after contrast, I think. Okay.
So there is apparently a fluid collection. It looks like in the right lower chest wall, subcutaneous. It's superficial to the. It looks like a peritoneal wall and the ribs. It looks like there's some lucency within the adjacent rib, suggesting I think this is just an involvement of that rib. Let's see, looking further down, it's kind of irregular appearance of the edges of that fluid collection. BCG osteomyelitis. Okay.
This is again BCG, which we're not going to see in the U.S. anymore. But this all turned out to be an inflammatory reaction from the BCG injection.
BCG injection is given. It's usually given in the
same patient.
I don't know. No, this is a different patient. So, Jonah, why don't you get? I don't on that last case. I don't know where it was actually given. Yeah, it's in the arm, and maybe in the babies in Korea, they gave it in the chest wall area. I don't know the details on that case. Jonah?
Certainly. So here's an ultrasound image of left axillary papillary mass. Apparently it went for excisional biopsy and was consistent with BCG-itis again.
So another one. Okay. So let's go on to something a little bit more practical here for us.
Okay, sagittal T1 and a coronal T1 weighted image, which demonstrates fatty atrophy of the teres minor muscle, and so be concerned for
Okay, so what would you be concerned about?
So this could be the innervation to the teres minor is from the axillary nerve. So the first thing I would do is look in the axillary.
Okay. So the axillary nerve comes off, as we can see here, through several different cords of the cervical spine, and primarily C5 and C6 when it comes off here, and then it comes around and innervates the part of the humeral head, as well as the teres minor, teres major, and part of the triceps, I believe. So let's see, Jeff, what do you think of this case?
All right, so we have these axial PD fat side images, and it looks like we have, I think we have a posterior labral tear with a paralabral cyst formation.
Going into what area?
Going into the, that would be the, it's Oh, it's going into the spinal glenoid notch
Right.
region.
The spinal glenoid
Right.
notch. And then what you'd be concerned about here, where would you tend to get the atrophy?
I would on the sagittal images, I would want to evaluate the infraspinatus muscle to assess for atrophy or denervation process. And on this T2, it looks like there is some increased signal within the infraspinatus, and makes me concerned for some neuropraxia related to the suprascapular nerve impingement.
And here's the PD fat set, and we're seeing some atrophy and edema here in the infraspinatus. So this is a case where the pathology read the book. So it's the proper location. Okay, and then that's entrapment of the suprascapular nerve, which comes down here. And if you have a notch in the suprascapular area, you're catching the nerve earlier, higher up, and you get both supra and infraspinatus. When you get down to the spinal glenoid notch, that's lower down, and you tend to get more isolated infraspinatus atrophy like we saw in that particular case. All right. John?
John?
Yes.
Can I go back a little bit before you finish TB? I got some statistics for all of you. In 2008, there were 12,904 new cases of tuberculosis in the United States. 59% were foreign-born.
Okay.
In 2006, there were 644 people that died of tuberculosis in the United States. The most common bone and joint disease is found in the spine, thoracolumbar, and then knees and hips. 1 to 8% of tuberculosis affects the skeletal system. And
yeah, we'll see some of those later.
Yeah, well, I didn't know whether you're going there or not. But this shoulder is not very often affected.
Good.
Then another thing I'll ask is, who wants to answer what actinomycosis is?
Okay.
Is it a bacteria or a fungus? Jonah? No, it's bacterial.
Bacteria, yeah. Oh, sorry.
I didn't know that either until I
misnamed.
Read up on it a little bit. It is definitely a bacteria. And then there's also viral synovial disease that I never heard of before, and it's varicella, rubella, and you get it from vaccines. You get synovitis, osteomyelitis from the same too. Variosa. Now that's just some little things that I accumulated in my brain a few days ago.
Thanks, John.
You're welcome. Now we can go back to the real stuff.
Okay.
Thank you.
Let's see. Jonah, what do you think of this case?
Certainly. So we've got a sagittal T2 of, now both the right and left shoulder of this patient. And, I'm looking at, say, Teres minor, I guess, on the left. Maybe we're not getting a good cut of it, but right there, especially compared to the right, it sure looks diminutive.
Okay. And so what are you worried about if you see that? On the right side, it's probably normal. So what are you concerned about?
Well, I'm concerned that there's a unilateral nerve lesion, posterior branch of axial.
So where would that be on the image?
So let's see here. On our image, we've got a little bit of kind of fluid coming around anteriorly.
Right.
Anteriorly.
Yeah, but that's not where the nerve is. Where's the nerve?
I'm just kind of saying some things I see. But then more, inferiorly is where we would expect that now.
So here's part of the area of the axillary nerve and vessels.
Mm-hmm.
And here's that area over here. So what's going on here?
Well, yeah, so we are seeing a little bit of kind of irregularity and abnormality of kind of a curvilinear structure there, and there's atrophy. Okay.
What's the diagnosis?
So, oh yeah, big lipoma pushing on it, yeah.
Yeah. So there's a huge lipoma here pushing on the nerve, and this was the source of the atrophy. And you can see it's very chronic here. There's no edema in the muscle. It's just very atrophic. So this lipoma has been there a long time, producing the chronic atrophy of the teres minor.
It's too obvious to see.
Yeah, sometimes the bigger it is, the harder it is to see. So here's the quadrilateral space in through here, and here are the axillary vessels and nerves coming out. And you can see they go to the part of the deltoid, they go to the teres minor, teres major, and the triceps area. Okay, here you go.
Okay, so we have a sagittal T2 and coronal T1 weighted image of the shoulder, and there's a distension of the joint space with some intermediate signal intensity fluid, and then there's discrete. Well, I see it more posterior inferiorly. Yeah, there, and then in the axillary pouch, there's some fluid too.
These are T1 weighted images. So, well, this is T2. I guess this is sagittal T2, but I don't see much fluid there.
And then there's atrophy.
This is a coronal T1.
And the T1, it's more, there's like this intermediate signal intensity in the axillary pouch.
Talking about this?
Yeah.
It's called an osteophyte.
Okay. So it's connected to the humerus. So that's what it is. So that's why there's so much atrophy of the teres minor muscle. Yeah, because it's pushing on the axillary nerve.
So the teres minor atrophy, and that's the osteophyte. And this is quadrilateral space osteophyte. And this is just the axillary nerve down here. And as we said, it's innervates teres minor, major, humerus, and the long head of the triceps. Okay. Jeff, what do you think of this case?
Boxer with asymmetric pectoralis, swelling 2 days after weightlifting. It looks like we have a coronal image of the pectoralis major muscle demonstrating diffuse hyperintensity through the muscle. And then on the axial, these are stir images, I think. Stir image, again, we're seeing a diffuse signal throughout the muscle. And so,
yeah, I think these are fat sap, but there's very similar contrast to a stir. Yep.
Essentially, I mean, it looked like he has high-grade strain of the muscular portion of the pectoralis, and I'm trying to. It looks like, in fact, maybe it's a partial tear, or it might be. Yeah. I mean, it looked like there was some irregularity of fibers there on that coronal image.
Yeah,
I'm sorry, not coronal, the sagittal image, which made me think it might be a partial tear. So
his symptoms didn't start right away. They took about a day and a half before his symptoms started, and the symptoms tend to peak about 2 days after the exercise, and this can take up to a week to subside. And it's called delayed-onset muscle soreness syndrome, and it's a very common problem with athletes. And it's due to a low-level strain, but as you can see here, you can get a lot of edema and a lot of the fibers involved, but most of these patients are asymptomatic within a week. If it's actually a tear, they tend to occur immediately at the time. The pain tends to occur immediately at the time of the exercise, and the symptoms can last much longer, as you all know, just depending upon the extent of the tear. But you can get a lot of edema within the muscles with the delayed-onset muscle soreness syndrome. Okay. So let's see. Jonah, are you next?
Sure, I'll take this one. So we've got an athlete with some shoulder pain. We have an arrow sign here. It looks like a T2 and probably stir PDFS. So let's see. This is patient's kind of supra-posterior thorax. This is some kind of fluid signal, kind of.
So what is this right here? What's this?
So I think that's going to be, we're pretty far back, so I think that's probably part of the scapula there.
Okay. And then you're getting some edema in the tissues between the scapula and the rib cage.
Oh, okay. Well, okay, so here we have that fluid signal again. Yeah, so the way that's described, that sounds kind of like a bursitis. Yeah, there we go.
Scapulothoracic bursopathy or bursitis, which can occur, and this is usually an overuse syndrome. You can do this. Okay, so here we go.
Okay, with that word, bursopathy.